Dr. Eric Jonasch, who proudly is one of Canada's prolific exports to the US. He is a medical oncologist at MD Anderson, but I believe did his training in McGill, if I'm correct. Um, and it's a delight to have Dr. Jonasch come. I first met Dr. Jonasch as a young faculty member in my first VHL meeting. I remember standing next to him beside this soft-spoken giant, but I knew he was Canadian because I could sense a big hockey stick behind him. So I welcome him, and he's going to talk about FDA approval of Belzutifan. So welcome, Eric.
Thanks, Raymond. Thanks all for attending, and congratulations on this fantastic meeting. So what I'm going to do is I'm going to go through things that a lot of you probably have already discussed, but really sort of talk a little bit about the history of how this agent was developed. And I don't think this audience really needs to be reminded of, the seminal observations in the history of VHL research with Eugen von Hippel and Arvid Lindau making the clinical observations that resulted in the coining of von Hippel-Lindau disease. Other important landmarks in 1993, the VHL gene identified, and I think as important, the VHL Alliance, at that point in time called the VHL Patient Alliance, formed by Joyce Graf, Susan Warnick, and Peggy Marshall. Work in multiple labs through the 90s into the 2000s, and a number of people on the call here, including Michael O, being important parts of this, as well as others, really discovering how VHL works and the downstream consequences of VHL loss. And then at UT Southwestern, Bruick and colleagues sort of understanding how one could potentially drug HIF2 alpha led to the development of a company, Peloton Therapeutics, which developed the first compound that really looked like it could be clinically relevant, and then switching over to a second generation one. And then the launch of the clinical trial for VHL disease, the acquisition of this compound by Merck. And then in 2019, Ratcliffe, Kalin, and Semenza getting the Nobel Prize, Physiology or Medicine, for their understanding of VHL. And then in 2021, the FDA approval. So it's been an incredible journey. And as you can also see, it's the work of many, many people who have done this. So once again, this is, Coles to Newcastle. You know how VHL works. Basically, in the pseudo-hypoxic state, you end up having abnormal or dysfunctional VHL, resulting in inappropriate heterodimerization of HIF1 alpha and HIF2 alpha, resulting in transcription of a number of different factors that are good for the cell itself for survival perspective, as well as for creating an environment that really would allow them to flourish. So can we block the consequences of VHL loss? And here there are multiple therapeutic opportunities when we sort of look at this cartoon of the tumor cells, this blank space of the microenvironment, which is obviously quite rich, but for the purpose of this discussion today, we will keep blank. We have the VEGF receptor, the VEGF ligand, the HIF2 alpha, the HIF itself, and sort of the holy grail, refunctionalizing or fixing broken VHL. At MD Anderson, we have been working on trying to understand whether existing assets that had been developed for metastatic renal cell carcinoma were of any value for individuals with VHL disease, starting with looking at sunitinib. This was published in 2011, moving on to dovitinib, and then pazopanib, and then ultimately to belzutifan. And each of these other drugs, which I'm not going to really go into great detail describing, had some benefit in kidney. In the case of pazopanib, minor benefits in hemangioblastomas and pancreatic neuroendocrine tumors, but definitely did not have the safety and side effect profile that would really be attractive for long-term use in individuals living with VHL disease. So HIF inhibition is certainly, one would think, be something that's analogous to, for example, VEGF inhibition, but obviously it's much, there's far many more downstream branches here, and so it's a logical way to actually interact with this biology. At UT Southwestern, the understanding of where we could actually drug HIF2 alpha was generated, and by, as I mentioned, and the PAS-B domain looked like it was an area where compounds could actually bind to prevent heterodimerization of HIF2 alpha and HIF1 beta. An initial sort of lead was created. It didn't have the right pharmacokinetic properties. It wasn't a drug. Therefore, a further iteration in this company that was called Peloton resulted in this initial first generation drug of PT2385, which went into clinical trials in people with advanced renal cell carcinoma and also initially in von Hippel-Lindau disease, did not have the right pharmacokinetic properties. And then you can see here the slight change. You can see the fluorines here that are moved from cis to trans. This modification resulted in a far better pharmacokinetic drug, and that was then called PT2977 and K6482, and that went into the registrational study for von Hippel-Lindau disease. And here we have the paper that was published last year, and the authors that were involved in this. And as you can see, it's an international effort. It's work of many people like Othan Iliopoulos, who've really been here from the beginning with regards to the development of our understanding of VHL biology, and folks from the NIH like Marston Linehan and Ram Srinivasan and many others around the country. So this study design really is kind of interesting in that with rare diseases, you have an opportunity, especially when there is no other agent that is approved, to do single arm studies. And this was a design that was approved by the FDA to take individuals and treat all of them with this drug. The study was originally powered actually to demonstrate efficacy with 50 patients, but there was a surge of enrollment late in the game. We ended up having 61 patients on this. The primary endpoint of this trial, again, when you design a trial, you need to make sure you have some kind of an endpoint that allows you to make clean and clear statements about efficacy. And this was a lot of discussion, a lot of debate about how, to design this. It was objective response rate in VHL-associated RCC tumors per RECIST 1.1. And our conversations with Peloton at that time and with the FDA, well, what about the hemangioblastomas? What about the pancreatic neuroendocrine tumors? What about the retinal hemangioblastomas? And what we succeeded in doing, and I strongly advocated for this, that the company then collect data very carefully and as if they were having a registrational approach to the other lesions as well, just in case, for serendipity's sake, we would end up having tremendous response and or simply needed to expand the sample size of this trial so that the objective response rate in the non-RCC lesions could also potentially be used. Imaging was performed every 12 weeks at baseline and every 12 weeks thereafter. MK6042 or PT2977 or Belzutifan was given 120 milligrams orally once a day. And for those who are on the drug or dispense it, that's 340 milligram tablets. The baseline characteristics of the individuals in the study were kind of typical for VHL type population, 41-year-old median age, male and female, even distribution. Performance status just by protocol requirement plus one exception, where it was a PS of 0 and 1, where one individual with a PS of 2 because she did not have sight. She was non-sighted, but she was allowed on. You can see also at the bottom, just because VHL, the number of individuals who had pancreatic lesions, 100% of them had pancreatic lesions. About a quarter had, a third had pancreatic neuroendocrine tumors. The majority had central nervous system hemangioblastomas, and 12 individuals with 16 eyes affected had retinal lesions. So it did give us the ability to look at these other organ sites in a reasonable manner. When this paper was published, 88.5% of patients were still receiving ongoing treatment, and the median time from enrollment to data cutoff in this paper, and I'm going to move on to the more recent abstract, which I think is very important to look at, was 21.8 months. So here is the table and the waterfall plot for objective response rate in the VHL-associated RCCs. We can see that this data cut, 21.8 months, we have an objective response rate of 49%. No complete responses. The vast majority of all of the responses are partial responses. No disease progression as best response. And this is actually a very important point, that at least in the initial sort of as best response, nobody progressed through this in the kidneys. We'll see with the later data that there are some people who are progressing, but later on, and I think that's an important distinction to make. You see the waterfall plot on the right, demonstrating the partial response rate, and the fact that the majority of individuals had some degree of shrinkage of their target renal lesions. This is a spider plot. And what we did here was to look at the change in the diameters of these tumors over time leading up to initiation of treatment. And then to the right of that inflection point, what type of decline, decrease in size of the lesions was noted. Those in green are the ones that had confirmed partial response. Those in blue were the ones who had a stable disease. And you can see the vast majority of these. First of all, you can see that there's this growth rate of about 4 millimeters per year. That you can see extending out to the left. You can see then after initiation of treatment that there's this nice decline. You can see the declines are greater in some than others. You can see there's that one rogue lesion that in blue that decided to take off. And that's actually something I'm seeing in clinic now as well. We have over 60 patients post approval who are on Belzutifan, and we are seeing this is very representative of post trial real life. This swimmer's plot demonstrates where at what point individuals developed their responses or didn't receive responses. And again, this is the 21.8 month follow-up. We can see the green dots are the confirmed partial response. And if you look at the scale on the y-axis below, you can see that the median time to response is actually about 8 months or so for renal cell carcinomas. It's quicker for hemangioblastomas, which is interesting. And then we can see the confirmed stable disease patients. And then at least here at this point in time, in terms of progressive disease, there were only 2 little black squares. As you know, we talked about serendipity before. In the pancreatic lesions, the pancreatic neuroendocrine tumors, and the central nervous hemangioblastomas, we saw nice responses. We saw 77% objective response rate in pancreatic lesions, 91% in the pancreatic neuroendocrine tumors, 30% in the central nervous system hemangioblastomas. Once again, looking at what I see is really, really important is, are we leaving people behind here? Looking at the PD rates, we see that only 2 of the hemangioblastomas had some progression as best response. On the flip side here, we're now seeing some, in this initial data cut, complete responses in 10% of the pancreatic lesions, 13.6% of the pancreatic neuroendocrine tumors, and 6% of the central nervous system hemangioblastomas. So this is definitely working in non-RCC lesions. The best response in retinal lesions, improved and stable, was actually all of them. And having interesting conversations with my colleagues like Dan Gombos in the ophthalmology world in terms of how dramatic are these responses. They're modest. The stabilization and or improvement are modest. But there's definitely individuals where this has been associated with an improvement in their sight. Probably my favorite figure of all time, and this was a collaboration between Merck and us, the investigators, to figure out how to best depict what's happening to these individuals before and after treatment initiation. So we have a swimmer's plot here again. What we have on the blue dots are interventions of any kind before the initiation of therapy, and this would be in any organ site. We see then the table on the bottom. There's the tally on the bottom, the number of procedures performed on average per year, leading up to the initiation of treatment, and then post the number of procedures performed. You can see only 3 in all 61 patients after initiation of treatment over that 21.8 month median follow-up, and you can see about 20 per year before. So a dramatic change. Adverse events, obviously very important, and for those individuals, patients and providers who are caring for patients, this is not a benign drug. We see here, just in terms of grade 3 treatment related in the 61 patients, there were 9 treatment-related AEs. Treatment discontinuation actually for adverse event initially only in 1 patient because of grade 1 dizziness. 1 individual actually passed away from a fentanyl overdose, not related to the study drug. But we are seeing in the real life that individuals are definitely getting fatigue. They're getting the anemia. There is some degree of hypoxemia, and this seems to potentially be age-related. So there are things that need to be followed here. Anemia, main thing, on-target effect. This is because EPO is a HIF2 alpha client gene. We can see the drop in hemoglobin. We see that a number of these individuals did get erythropoietin stimulating agents. Some didn't, but we do see tachyphylaxis. You can see the stabilization here, and the number of individuals that did require some sort of intervention or maneuver to raise their hemoglobin was relatively minor. Approval, August 13th, 2021, and it was for renal cell carcinoma, central nervous system hemangioblastomas, and pancreatic neuroendocrine tumors not requiring immediate surgery. So here, once again, be careful in how you collect your data. Make sure that you are ready for serendipity, and this will allow for things that you don't expect. We did not know what the approval would look like, and we were delighted to see the broader label. Here are the follow-up data. I think this is really important. Now that we have longer follow-up, let's see whether this really is durable, because we now have some individuals who are on this drug for several years. And when you're talking with a 22-year-old person who's committing to getting onto this, what does this look like? And is this really worth it? Is this going to have some sort of long-term negative consequences? I don't think we really know the answers to these questions, and we have to be extremely humble, very careful, continue listening to both our patients and each other to make sure that this is really an exercise worth pursuing. This was Ram Srinivasan presented this at ESMO this year. Now, median follow-up of 37.8 months. And at that point in time, we have 23 individuals who've discontinued on this trial out of the 61. 11 patient decision, and we have people, for example, it's quite onerous to participate in a clinical trial from the standpoint of travel, additional tests, etc. We see that there are 6 individuals who had progressive disease for VHL-associated RCC, so it's gone up. 2 adverse events, 2 deaths. One actually person committed suicide on top of the person who had the fentanyl overdose. Just demonstrates, I think, in terms of some of the unmet needs for this patient population in terms of just support, psychological and otherwise. 1 individual that became pregnant and 1 was other. So people are coming off. But as we see here with this waterfall plot and the numbers, that the objective response rate for the renal cell carcinomas has now risen to 64%. We now have 7% complete responses and 57% partial response. And so we are seeing that the responses that are occurring are durable. Having said that, there is a set of individuals where these lesions are starting to progress. So here we have now the swimmer's plot again that you saw before, and we see now that the number of black dots is increasing. So we do see progressive disease occurring in a subgroup of individuals, and you can see that there's a little bit of a clustering to the right. As time goes on, we are seeing some individuals who are having progression. And I think this is a very, very important point, and we have to make sure we work together as a group to better understand this. Some of you may know I was awarded a DoD consortium award to work together with centers to be able to gather large amounts, as large amounts as possible, real world data of individuals on Belzutifan, so we can really understand this better. Here now are waterfall plots for central nervous system hemangioblastomas and pancreatic neuroendocrine tumors. The pancreatic neuroendocrine tumors, see the number of complete responses here, really quite impressive. Central nervous system hemangioblastomas, again, we see that the majority of individuals having some degree of shrinkage here. Here's now the that modified swimmer's plot of VHL related interventions. And so we can see the pre on the right, on the left, and the post on the right. And we see now here, there is a scattering of those black dots, the renal cell carcinoma progression. We see the central nervous system, a couple of central nervous system progressions, a couple of retinal progressions. Now, this doesn't mean that the patient isn't continuing to benefit and shouldn't remain on trial. What we're seeing in the real world is we're seeing that there may be rogue lesions that need intervention, but the patient is still benefiting in other organ sites. And so this integration then of procedures where necessary, plus treatment when necessary, is I think an important way to refine our approach to this to the use of this agent. Adverse events, really no major additional signals. We see now we have, instead of 9, we have 11 grade 3 treatment-related AEs. We see the number of dose interruptions because of an AE occurring in about 43%, dose reduction in 16%, treatment discontinuation because of an AE in 7%. So, and no deaths because of a treatment-related AE. We're not seeing, as we saw with pazopanib, for example, we didn't have any deaths on pazopanib, but we did see some central nervous system hemangioblastoma hemorrhages. To my knowledge, we're not dealing with treatment-related catastrophic events yet with this agent, but again, we have to remain vigilant. The adverse events with incidence greater than 20%, we're seeing here, once again, anemia, fatigue, and this is really, really important. We don't have hypoxia on here, but definitely we have had some individuals in the real world that have mentioned that, and I think it's something we need to be very careful of to better understand. So in summary, VHL disease is an autosomal dominant disorder that impacts numerous organ systems. Our understanding of VHL biology has led to the development of agents, including the HIF2 alpha inhibitors. We got FDA approval 2021. And this really, we cannot emphasize how much this is a collaborative effort between multiple centers of excellence, incredible researchers, patients, the patient community, and this drug, we now are moving on to seeing that this is quite helpful in the metastatic setting. This is a drug that's likely going to get approved as monotherapy, I guess, in the advanced RCC setting. It's being looked at orthogonally in other tissue types. For example, pancreatic neuroendocrine tumors are only the VHL lesion-derived ones, the ones that are going to benefit, or can you look at pancreatic neuroendocrine tumors with other genetic backgrounds, and can they benefit? Same with pheochromocytomas. So there's a lot of promise for this agent. A lot we have to learn about what should it, it's working pretty well. How can we actually enhance its function? What do we need to combine it with? That requires tissue-based studies that, unfortunately, at this point in time, are not being done by industry to allow us to better understand what's really happening at the microenvironmental level with this agent. And these are the sorts of things that we're going to be very busy with. We've got a great start here. We need to keep on pushing. We need to keep the quality of the science and the work at the highest level possible. Obviously, a huge list of individuals, and I am missing many, many people in this here. Jim Brugarolis at UT Southwestern, Ram Srinivasan, Othan Iliopoulos, Marston Linehan, obviously the Nobel laureates, the clinical team at my institution, and obviously all around the VHL Alliance. And I still have Chandra up here. I've really enjoyed working with her. I wish her the best for her future endeavors. The past other presidents, Eileen Sussman, Joyce Graf, Merck, the Merck team really, and the Peloton team. So I'll stop there, and thank you very much for listening.
Thank you, Eric. I think we have time for a couple of questions. I have a few, but I wanted to give justice to some in the chat. The first is from Rachel Giles. The FDA approval of Belzutifan based on safety from 61 patients, but the EMA requires more safety data prior to consideration in the EU. Can the real world data be collected and bundled and submitted to assuage the EMA concerns?
So this is a very good question, Rachel, and indeed what we are doing. Well, Merck is sponsoring the acquisition of said data in the real world, and there will be a trial that is going to be opened to do so to help us with the EMA. As I mentioned, Rachel, I'm also, independently through this DoD grant and other support, we are going to be gathering data from, we're starting off with the biggest centers in the US, and we want to add on to that as our infrastructure, data collection infrastructure improves. Critically important that we gather these data so that we can satisfy the EMA's exigencies.
Great, thanks, Eric. Another question in the chat. Thank you for your excellent review of the data around Belzutifan. May I ask how you manage the use of Belzutifan in young patients who are wishing to conceive or breastfeed? Do you advise them to stop Belzutifan at the time they attempt conception and continue to hold until they are done breastfeeding? It seems that Othon touched on this yesterday, but perhaps Eric, you can expand on that.
Yeah, and we absolutely, this drug should not be used in individuals who are planning to have a child, both males and females. What we're generally asking young individuals to do, or recommending for them to do, is to if you're a man, to sperm bank. If you're a woman, we don't know the long-term consequences of this on fertility, and we are asking for them to consider egg banking to make sure that we don't lose the opportunity for a woman or man to conceive. Absolutely, if you are planning on starting a family, you would not want to be on this drug, and you want to stop it probably for at least a month or so before if you wish to conceive in the natural way, if you will, but also during, if you're going to be doing pre-implantation genetics, etc., you can't be on this. Breastfeeding, don't know, but I would just say probably out of an abundance of caution, it would be probably wise to avoid. But I'm not sure whether we have information on content of this in breast milk. I mean, it just would be we don't have enough women where we'd be able to gather this data, but probably would be good to avoid.
Thanks, Eric. One last question that we'll take from Franco Pradelli is thanks for the great talk regarding CNS hemangioblastoma. Could you observe if regression is caused by increase in tumor cell death or as a consequence of the regression of the retinal network that reduce nutrients available for the tumors?
Good question. We don't have tissue to demonstrate what exactly is happening there. So we don't know whether this is simply a microenvironmental shrinkage or whether this is actually a decrease in actual hemangioblast numbers. Because if you look at it in hemangioblastoma, the number of stromal neoplastic cells to other stroma is there's a far greater number of the other cells. Therefore, I would assume it's probably to a significant degree a modulation of the microenvironment itself, a decrease in the vascularity, a decrease in the other stromal cells as much as the hemangioblasts themselves.
Okay, thanks. Sorry, Michael, we will have to move on.